Over the past 5 months, I have interviewed 161 Kaposi Sarcoma patients in Uganda. Many of the faces and stories run together, and I probably could not identify one of my interviewees on the streets outside of a few of the more memorable patients. Their faces stay in my mind's eye for various reasons, some humorous, some frustrating, and some heartbreaking. E is one of those patients. He was first diagnosed with HIV 7 years before the day I interviewed him in his bed, and he had initiated antiretroviral medication 2 years after that, meaning he'd been on treatment for 5 years. He admitted that his adherence was sporadic at best, even going through stretches upwards of 6 months without taking his medication. He understood that he needed the treatment, but he was constantly moving back and forth between Kampala, the capital city, and his rural village, trading produce in the big city to support his family back home. At that time, he was earning around 250,000 Ugandan shillings per month, which is just over $3 US a day. He first remembers dark black spots appearing on his forehead, legs, and hands about a year ago, but he didn't have any pain, and he thought that the spots were associated with his antiretroviral medication. So he didn't say anything to anyone. Within a few months, however, he began to develop some pain in his feet, and he noticed that his lower legs would be painfully swollen after a long day of work. Things continued to slowly deteriorate for him. He began to notice more spots on his back and stomach. The swelling became more and more painful, and he began to find hard nodules on his upper thigh. Still, he continued working, refusing to seek treatment for fear of losing his job and failing his family back home. Finally, nearly after a year of first noticing his black spots, E was brought to the Uganda Cancer Institute by a coworker who had found him at home, unable to move from his bed. His health had plummeted in the last month, and he was admitted to the ward with a racking cough suspected to be disseminated pulmonary KS, Kaposi Sarcoma, or TB. He had fungating septic lesions on his upper thighs. His face, arms, and legs were covered in dark black splotches. He was wasted and malnourished with a CD4 count of 80 cells per microliter. E died 2 days after I interviewed him, a fate that statistically 80% of all patients living with Kaposi Sarcoma in Uganda face, although more than half of them never even reached the Uganda Cancer Institute for definitive treatment. E faced significant social and economic barriers that helped him to cause his delay, that helped cause him to delay his care. When I asked him what he thought his disease was initially, he scoffed at the idea of understanding it as cancer. No one knows what cancer is, he told me, describing it as some sort of abstract and mysterious disease. That's always a death sentence, usually brought on by someone trying to bewitch you. His story may seem a bit dramatic, but unfortunately, E is closer to the rule for KS in Uganda rather than the exception. To be sure, strides have been made. I have interviewed a number of KS patients who chronically manage their KS. And it's not only men either. Women and children are increasingly affected and succumbing to the same outcomes. There is a common theme, though, through many of the stories. Delay. Why did E delay his treatment for nearly a year? And what role did this delay play in his sickness? What would have been the outcome if he had sought his treatment immediately after noticing those characteristic spots? How can we work to ensure that stories like E's become the rare exception, so that the downward spiral he experienced when he delayed his treatment can be avoided? I told you that story today because that's really what I want to focus on, is the concept of delay, and particularly when we're talking about cancer patients. Particularly the kind of cancer I want to talk about is called Kaposi Sarcoma. It's a malignancy related to HIV. I'll go more into the details of what it is later. But I really want to talk about the relationship between delay and Kaposi Sarcoma. Delay is certainly not a new concept when we're talking about healthcare in low-income contexts, and it's not a new concept or a new factor when thinking about poor outcomes. In fact, it's actually been the subject of some of our most renowned speakers worldwide. Even as a prominent feature of the writing of economist Amartya Sen, a Nobel laureate, he says, "The poorest groups not only bear higher risks for non-communicable diseases, but once they develop such a disease, they also face larger medical and economic adversity. The poor have less resources and less access to medical care and often have delayed diagnosis. Diseases like cancer tend, as a result, to progress to more advanced states than in the case of the rich, and this leads to higher levels of mortality and disability." So as we go through our talk today, I'll be referring back to this quote by Mark Toussaint and the story that I just told you. And that's sort of going to frame our discussion today. Before we go any farther, though, I want to talk about our discussion and make sure we realize this is occurring in the context of global cancer. What you're looking at is a graph of global cancer incident cases, so the number of new cases every year. And it's from 2000 to the projected cases in 2030 on the x-axis, and then the total number. The top line is the total cases, and the bottom line is total mortality. And as you can see, globally, we're experiencing an increase in global cancer. And as far as we can project from the data we have, it's only going to continue increasing. Yeah, near
Is that millions? Yeah.
Yes, sorry, millions. Interestingly, though, the rise in incident cases and in total mortality is not happening uniformly globally. Is there another question? Or no? Okay. It's not happening uniformly across the globe. And what we call this is the cancer divide. The cancer divide refers to the unequal distribution of incidence, mortality, funding, and access to medications when we talk about cancer. And I put this picture of the Duke Cancer Center up here, which is brand new, just to illustrate sort of what we're talking about today. Cancer is something that's pretty ubiquitous in Western society. We probably all know someone who either had cancer or died from cancer. And we sort of built up these types of institutions of cancer research. It's been a big focus of policy in the last 50 years in the United States. But what does cancer look like in a place like Uganda? And this is the Uganda Cancer Institute in Kampala, where the patient story that I told you took place, and was the place for the research that I'll be talking about today. We really can't talk about delays in Kaposi sarcoma without talking about the inequity, and that's really what we're all here for and what we've been focusing on our research in. So this is a figure that sort of explains the root of the problem. We call it the 580 cancer disequilibrium. And what you're seeing here, let's first take high-income countries. You can see the disproportionate amount of global expenditure to global burden. So in high-income countries, 80% of the global expenditure for cancer is spent, but they only have 5% of the global burden. And you can see the opposite is true in low-income countries. Even though they have 80% of the global burden, they only have 5% of global expenditure. It's also important to note that when we talk about global burden, we're not just talking about death. We're talking about disability-adjusted life years, which is a measurement of the social and economic costs also of cancer. So this is also people who are losing jobs and the economic costs as well. This is just another graph that is explaining the same thing. On the y-axis, we have the ratio of mortality to incidence, and on the x-axis is country income classification, and then these are just a range of cancers. You can see an overall downward trend. Basically what this is saying is you're much more likely to die of the same cancer in a low-income country than you are in a high-income country. So if we take, for example, the green line is non-Hodgkin's lymphoma. About 5 out of every 10 patients are dying of that in a high-income country, but 8 out of every 10 are dying of non-Hodgkin's lymphoma in a low-income country. So you can just see the disparity there.
Can I ask you a question?
Yeah.
Why does there, this may be totally outside your purview, so you can tell me to shut up, but why is there a spike in mortality for high and middle-income countries over lower middle-income countries?
Yeah, that's a great question. Some analyses have shown that there's a threshold for some cancers where no matter, it has to do a lot with the economics and cost efficiency of what you can do with so much money. And I would speculate maybe that with some of those cancers, you hit a sort of threshold with your funding, and then maybe once you can get over that threshold and forward the next line of treatment or the next sort of rate of therapy, that you would get over that spike.
Yeah.
I'm starting to get on a tangent, but a lot of research that looks at chemotherapy regimens looks at sort of how much bang for your buck you can get, and they look at like, oh, you can put 10 grand into the second line treatment, but you only get a few months out of it.
Yeah.
And it's sort of when they add the next line of treatment that they really sort of make a breakthrough. So I would guess it might have something to do with that.
Thanks.
But the question that we're sort of left with the cancer divide is why. I've shown you sort of the indices of inequality and why. Funding obviously is a huge part. We've talked about the disequilibrium. It's just an unequal distribution of resources. But we do know that there are a lot of other sort of factors as well. Changing behaviors and habits is one. Unequal distribution of risk factors, such as higher tobacco smoking in low-income countries. And increasing changes in eating habits. There's also less environmental protection in some of these low-income countries where we know there are cancer-causing agents in work environments especially. There's an aging and growing population in low and middle-income countries. We have a new demographic that's susceptible to a lot of the cancers that have been plaguing our elderly for decades. And then also a higher rate of cancer-causing infections. And that's what we're really going to focus on today. Kaposi Sarcoma, the cancer of interest, is caused by human herpes virus 8, which disproportionately affects low and middle income countries. For example, Uganda, which is the country of focus, has rates of seroprevalence, so how much HIV is in the general population, and is 10 times higher than a lot of populations here in the United States. So you just have groups that are much more susceptible to getting cancer. Not only are they more susceptible, but they're preventable. Almost 33% of cancer cases in sub-Saharan Africa could be prevented if we just had infectious disease control. So immunizations, a lot of the public health things we take for granted that aren't in place in sub-Saharan Africa could prevent a lot of cancer that's occurring. Also screening and things like that. And this just explains what I just said. Rates of infection-associated cancers are 2 to 5 times that of developed countries. So this is sort of an interesting thing to think about as well. We have a lot higher incidence rates of some cancers that are sort of characteristic of the wealthy, like colorectal cancer, bladder cancer. But something like Kaposi Sarcoma that we're talking about today, the rates are reversed. They're much, much higher in places like Uganda. And this graph just shows that. We have development status of countries separated by less developed and more developed. And then this is just the total number of cases that are attributed to total number of cancer cases that can be attributed to infections. So there's about 6 times as many cases that can be attributed to Hep B and C, and also Epstein-Barr virus. 10 times as many cases that are attributed to human herpes virus 8, which causes Kaposi sarcoma, which is what we're talking about today. Twice as many cases that can be attributed to human papillomavirus, which is mostly cervical cancer. And then, of course, we can't talk about infection and cancer without talking about HIV. And as I'm sure you know, of the 33 million cases, 80% of those are occurring in sub-Saharan Africa. And HIV is not causative for cancer, but has been shown to be linked to cancer. And of the top 10 most common cancers in sub-Saharan Africa, 3 of those have been shown to be linked to HIV, and with cervical cancer being number 1. And Kaposi sarcoma, which is what we're talking about today, is number 6. And then non-Hodgkin lymphoma, also related to HIV, is number 10. So on top of the funding, on top of the changing behaviors, on top of the higher rates of infection, you also have a population HIV that also makes them susceptible to these cancers. So what is HIV-associated, or what is Kaposi sarcoma really? It's what we've been talking about a lot. It's important to know there are 4 different variants, and HIV-associated is just one kind of Kaposi sarcoma. They all present pretty much the same, but HIV-associated is quite a bit more, how do I say it? It proliferates a lot faster and a lot quicker, more rapid progression, and that's really due to the lowered immunity. So as I said, it's caused by human herpes virus 8, which primarily infects endothelial cells in the skin, in the feet, but also the oral mucosa of your mouth and nose. And it presents primarily as cutaneous lesions, which is a little bit different from like your classic solid tumor. It can become septic and fungating, and then also causes dark splotches called hyperpigmentation, and then lots of swelling. And this picture here is taken from Uganda, and it might seem like a dramatic case. You see his leg is showing a lot of the things I just talked about, the lesions around his ankle there. But unfortunately, this is sort of a common presentation in Uganda, especially among men. It presents a little bit differently in men and women, but to see like the grossly swollen foot with the lesions like that is not uncommon. And then this shows the hyperpigmentation, that sort of blackening and cracking of the skin. So not a pretty disease, interviewing patients, they attributed this a lot to witchcraft and bewitching. I mean, if this started happening to my foot, I would probably think the same thing. So where we are, we want to focus in specifically on the country of Uganda. And Uganda lies right in the middle of what's known as the KS belt. And it's really where Kaposi sarcoma, or KS, is the highest. And that's right, Uganda sits right over that purple area, which is the highest incidence of KS. And so it's really a country of focus when we're talking about Kaposi sarcoma. So I just want to look at this graph when we're talking about Kaposi sarcoma in sub-Saharan Africa, and specifically within Uganda. If we focus first on the purple line, you can see time. This is time lasting from 1987 to 1997, and this is the age standardized rate per 100,000. So basically just the incidence. And the purple line represents San Francisco in the United States. Kaposi sarcoma was first really discovered as AIDS-defining illness in the United States at the advent of the HIV epidemic, which was discovered among gay men in San Francisco and New York. I'm just wondering if anybody can guess why the rapid decrease in incidence from above 30 million to about 2. Any ideas?
ARVs?
Yep, exactly. So this is, antiretroviral medication was discovered in the late 80s to be extremely effective in controlling HIV. But it's also extremely effective for controlling a lot of the infections, opportunistic infections that go along with HIV and cancers like Kaposi sarcoma. And then if we turn our attention to the green line, that's Chandondo County, Uganda, which is the county that Kampala lies in. And you can see that exact opposite going on here. The late 80s is really when the HIV epidemic started to hit sub-Saharan Africa hard. And over the same rate, sub-Saharan Africa did not have the access to ARVs that we had. And you can see the exact opposite effect. From a very low incidence of KS up to higher than what it was in San Francisco at that time. And that can be really attributed to the lack of antiretroviral medication, which is changing. We're starting to see now a leveling out of incidence since 2003 and PEPFAR and the introduction of antiretrovirals into places like Uganda. But in Uganda, ARV access is still around 40%. So we haven't seen a decrease like we're hoping. And again, the question is why? Why these gross inequalities? Some of them have been attributed in previous literature to poor coverage and failure of ARVs, which is really the crux of what's going on, and you can just see what impacts we could have with increased ARVs. Just a side note, HAART stands for highly active antiretroviral therapy, and it's just the standard high acting course of antiretrovirals for HIV. And then just being based in Uganda, a lot of poor outcomes based on nutrition, based on gender, noticing poor outcomes for women, the higher load of the virus, which I already talked about, and then just a lot of previously untreated conditions, so sexually transmitted infections and things like that.
Can I ask
Yep.
a question? You might be getting to this, so if you are, but when you were in the hospital and in, I don't know if you went to any clinics, but how was HAART readily available? Because you said that with E, that he would take it sporadically. Is that because it wasn't available to you? Or
It's available.
is it free? I mean,
It's free. It's available and free, but the locations, the locations and accessibility don't meet the demand. So it's really difficult for people who are migrating between urban and rural. There isn't transportation provided to these places. In rural settings, it's pretty much a walk-up line where you tell the doctor how many pills you have and how many you need, and he hands them out. There's just a huge range of HIV care in Uganda. It goes from what I just described in rural areas to comprehensive NGOs where you get counseling, nutritional supplements, maternal and child care, and things like that. So it's really a wide range. But largely the rural population has a lot of access issues to ARVs. So those are some of the reasons we know we're having poor outcomes for KS patients. But something that's been sort of unexamined in the literature and something that was illustrated in our story is the concept of delay. So I just want to go back and rethink again about delay. This is another factor that we could intervene on that we haven't really looked at. And that's not only true for Uganda, but it's true in low and middle income countries in general. I think delay is talked about a lot anecdotally, but it's not something that we've empirically measured in a lot of contexts. Yeah?
Sorry, can I just ask a biological question?
Mm-hmm.
So if you have the HHV8 virus in you, and then you start to display symptoms of KS, and then you go on ARVs, are ARVs sufficient in stemming the symptoms, or do you have to go on chemo, or what's the...
Yeah, we'll get into that more. Yeah, maybe I'll save it and we'll get into it. But yeah, but ARVs are very important for treating KS.
Okay.
So yeah, really what I wanted to focus on was sort of the factor that seems to be missing. I'm sure there are many more, but one of the missing links has really been delay. So what do we know about delay? Delay in cancer diagnosis and treatment has been talked about quite extensively because it's very important for something like cancer. And it's been a topic of discussion, especially in the West and in the United States for the last half of the decade when a lot of research was done on cancer in the 50s. And we do know from the literature that delay is associated with advanced cancer stage and poor outcomes, which might seem obvious. If you're sick and you wait, you're going to get sicker. But it's not necessarily true. That link hasn't been shown in all cancers. And in fact, in cancers which present much differently, sometimes the delay is even beneficial. So it shouldn't be assumed. What else do we know about delay? This is really sort of the impetus and motivation for my research was Dr. Nixon Niyonzima study, who was a graduate of the MSc-GH here. And he found at the Uganda Cancer Institute that 27% of adults with HIV-KS were experiencing delay in treatment initiation lasting more than 3 months. That was really the crux of his finding. But coming out of that, he had the question of, well, what's the effect of the delays? And talking with him sort of helped me guided me to think about that question. So yeah, Exactly what I just said. What is the impact of delay? That's the question we're left with. I'm going to talk about what's the definition I'm using when I'm talking about delay, because it can mean lots of things. This is sort of the accepted clinical definition of delay. It can be broken down into three different areas along the signs and symptoms to treatment continuum, sort of the whole pathway the patient goes through. Primary delay is when a patient first notices, the time a patient waits from signs and symptoms until they present. Secondary delay is the time from first presentation to diagnosis. And then tertiary delay is the time from diagnosis to treatment. Primary delay has been sort of the most focused on aspect in the literature, and we sort of have an accepted definition for that one as well. And that is that primary delay occurs when a patient waits longer than 3 months after seeing signs and symptoms. And that's the definition that I'm going to be using, and primary delay is what I'll be focusing on most, because that's sort of the most defined and accepted value. So just why the study? This is sort of repetitious, but we've seen low incidence of AIDS-associated KS and increased survival. We know it's possible to get better outcomes with this disease, but we still see, we're not seeing that in places like Uganda. And what's the reason why? We know some things, but others have been left unexamined, especially delay. We had two aims. We wanted to measure the association between primary delay, which I just talked about, that's waiting longer than 3 months, and overall poor stage risk. In cancer, you always stage a patient to find out what their prognosis of survival is. We didn't have the time to follow patients, so we used their stage when they were admitted to sort of gauge the overall health. The hypothesis was that those who experienced primary delay, so those who waited longer than 3 months, would be more likely to have an overall poor stage risk. And then secondly, we wanted to know which characteristics are associated with delayers. If we're going to intervene in any way, we need to know who these people are, what are some factors we could intervene on. And one hypothesis we wanted to test was that those who are already in HIV care would be less likely to experience primary delay. The rationale being, if they're already in the health system, they would be less likely to present to a clinician. So we did a prospective cross-sectional study of 161 patients that had histologically confirmed AIDS-associated KS. And the standardized interviews measured the treatment delays, so that's how we measured how long they waited, the 3 months, and then also the demographic variables, and especially their history of ARVs, which is important to know. The study was conducted at the Uganda Cancer Institute, at Mulago Hospital in Kampala, which is the only definitive cancer center in Uganda, and Mulago Hospital is the main government referral hospital. Our inclusion criteria were that they had to be adults, greater than 18 years, they had to have histologically confirmed KS, they had to be HIV seropositive, and they had to have a CD4 count performed within 6 months of admission. The CD4 count is a count of a special white blood cell that HIV particularly targets, and that's what lowers your immunity. And the reason why it had to be within 6 months is because we wanted an accurate measurement of their health at the time of admission. So our independent variable, patient delay, as I said, is primary delay. So within those, measured as those 3 months. So we just split the cohort into two sections. A delayer was someone who waited longer than 3 months, and a non-delayer was someone who presented within 3 months. And that was collected through standardized interviews. The dependent variable is the cancer stage. How staging works for Kaposi sarcoma is a patient is assessed in 3 areas, and then they're given either good risk or poor risk in each of the 3 areas. And if a patient has poor risk in all 3 areas, they're given an overall poor stage prognosis. So then we split the patients into 2 groups, overall poor risk and overall good risk. And only the patients who had poor risk in all 3 categories were defined as overall poor risk. Everyone else was put in the good risk category. So there are 3 categories. The first one is tumor extent. And you can see, so anyone with tumor-associated edema or ulceration, or had extensive Kaposi sarcoma in their mouth, or it has spread to their gastrointestinal system, is given poor risk. If it's just confined to the skin or is minimal disease, it's good risk. Immune system function is pretty straightforward. If their CD4 count is less than 150 cells per microliter, it's poor risk. If it's higher, it's good risk. And then systemic illness is the 3rd category. If they have a patient was given poor risk if they had any history of an opportunistic infection or any B symptom, and those are unexplained fevers, night sweats, greater than 10% weight loss, or persistent diarrhea. And they were given poor risk. So this is what a staging would look like. A poor risk patient would be given T1, I1, S1, which means they have poor risk in each of the 3 categories. And then any other combination would be good risk. So a patient with T1, I0, S1 would be a patient with poor risk and the tumor extent in the systemic illness category, but good risk with their immune system function. So we store data in Excel and analyze this data. Made descriptive statistics to find out who the patients were. And then to measure the association, we used logistic regression. So to answer the first aim, we measured the association between primary delay and overall 4-stage risk. And then to measure the second aim, we measured the association between different patient characteristics and primary delay. And those generated prevalence odds ratios. And then we made multivariate models to adjust for different confounding variables. We wanted 168 patients. You can see the power calculation there. And just to note, this was approved by the Duke IRB and the Makerere College of Health Science Research Ethics Committee. Mulago and the Cancer Institute is part of the teaching hospital, so that's what their IRB process is. So this is what we got. We looked at 265 files to see if they're eligible. 93 didn't meet inclusion criteria, so they had a different kind of KS, which was quite rare. Or they were children, or they didn't have the CD4 count within the range we wanted. 10 declined participation, so we had a 90% response rate, which was quite good. And then we had to reject 7 for data quality. So we ended up with 161 subjects. So let's get into the results. Just some patient demographics. The far left column is our cohort of Kaposi sarcoma patients. The rest is Kampala and overall Uganda. These aren't KS patients. These are all people. The mean age obviously is higher because we're only looking at adults. Income, quite a bit lower than Kampala and overall Uganda. I think that just sort of reflects the burden of the disease we talked about. A lot of people didn't have any income because they were put out of a job because of this. In percent educated falls somewhere in the middle. And then the male to female ratio was 2.12 to 1, which you would kind of expect based on previous KS cohorts. And just to note, ours was slightly higher than traditional values. Most report about 1.7 to 1. Sort of a unique, or not unique, but an important characteristic of the cohort was that a lot of them had a lot of previous HIV exposure, whether treatment or in clinics. So actually 48% of them had already been on ARVs for longer than a month. And that's important to know because, like your question alluded to, Maddie, you wouldn't expect patients on ARVs to develop KS and to develop extensive KS. So that was kind of interesting to note. Nearly 20% had started, and then some of them were on Septrin, which is a prophylactic drug sort of to control opportunistic infections. And then only 7% had never been to an HIV clinic, never had any counseling, never had been on any treatment. Give me 5 seconds. Age distribution, slightly higher for men than women. That's sort of a common thing that's seen with sexually transmitted diseases, just to lots of factors that go with sexual debut, gender-based violence, things like that. So a slightly higher distribution for men. So really the primary findings, 45.3% experienced that primary delay that I talked about. So 45.3% waited longer than 3 months before they presented to a clinician with signs and symptoms of KS. And then if you remember the other two parts of the continuum, secondary delay and tertiary delay, we're actually pleasantly surprised with what we found here. The majority and secondary delay were delaying somewhere between 2 weeks and 1 month. And that's, if you remember, the time from presentation to a clinician to a diagnosis. So a lot of that is more dependent on health system factors than patient factors, although a patient does play a role in that. And then tertiary delay is the time from diagnosis to treatment. And again, the majority within a month. So we'll get more into like what other literature says about that, but sort of happy with that. 28.6% had the overall poor stage risk, so poor risk in all three categories. And among all the patients, all stages, almost 92% had poor risk for extent of tumor involvement. Almost 40% had poor risk for the immune system function, and nearly 3/4 had poor risk for the presence of systemic illness. But again, only 28.6 had poor risk in all three categories. This is the distribution of staging that we saw. So on the x-axis is all the different possible combinations of stage, and then this is just total number. You can see the highest one is poor risk in tumor and systemic illness, but good risk with immune system function. And the second most was our variable of interest. Our outcome variable was poor risk in all three categories. So the results with respect to AIM-1, which was the association between primary delay and overall poor stage risk. Trying to answer that question, what is the effect of delay? And this is the multivariate analysis. So you can see here the odds ratio is 3.41. That means patients who experienced primary delay, patients who waited longer than 3 months, were 3.41 times as likely to have an overall poor stage risk than those who did not delay. Supports our hypothesis that people who wait have poor outcomes. And then these are the covariates we included in the model. Gender and age were put in the model because they were also associated with stage risk in univariate analysis. And then income and exposure to heart to ARVs were put in there just based on clinical and literature knowledge. And like you said, Maddie, again, you would expect that people exposed to ARVs would be less likely to have a poor stage outcome because they've been on that treatment. Yeah?
So, can we go back to the last slide?
Yeah. This one?
Or the graph. Yeah, that one. So, because the highest number of patients that you saw had a good outcome for immunity, does that mean that 150 CD4 isn't the right cutoff for?
Yeah, another interesting question. So the original staging had a cutoff of 200, and then that cutoff was validated in a survival analysis, and the staging group, which is the AIDS Clinical Trials Group, which does a lot of HIV work here in the United States, determined statistically that 150 was the best cutoff. But that's been called back into question because a cohort in the United States is very different than a cohort in Uganda. It was also done in 1997, and which means a lot of the cohort wasn't exposed to ARVs for long periods of time. So there's questions about how good the 150 cutoff is. But statistically, 150 is supposed to be able to tell you statistically the difference between poor risk and good risk. So this is just a plot of what I just showed you. You can see primary delay is trending towards poor risk, and then these are the covariates. And you can see none of them are statistically significantly associated with poor risk. The bar is the confidence interval, and it's crossing 1, so that means it's not significant. But like you said, this is exposure to heart, the last one, is trending towards good risk. That means people who were exposed to ARVs were more likely to have a good risk outcome. Although after controlling for variables, although it's not statistically significant. Age, older age, trends towards poor risk, which you might expect, and then gender, actually female, being a female trended towards good risk, which sort of goes contrary to literature. So that was just another interesting thing we found. So aim 2, patient characteristics associated with primary delay. We took a range of variables to try and predict who are primary delayers, and we found that only visitation to a traditional healer predicted a primary delayer. So we took that and entered that into a multivariate model as well, and found that those who visited a traditional healer were about 2.7 times as likely to delay their treatment, to wait longer than 3 months, than those who did not visit a traditional healer. Obviously, we're not defining traditional healers as part of the health system, which is another thing we could talk about. And then selected covariates. None of the covariates were associated in the univariate, so all of these were selected based on literature, direct acyclic graphing, which we all love, and those kind of analyses. So that's why they were anchored in the model. And this is another graphical representation of the same thing. You can see visitation traditional healer is significant and is associated with delaying. And then this, we did one final multivariate model to test that hypothesis that I talked about. That those who are in HIV care would be less likely to delay, and we did not find an association there. You can see the p-value is greater than 0.05, so it's trending towards a finding, but we can't say for sure. So at the end of this, we can only say really that those who visited an HIV clinic were no less likely to delay than those who were not in an HIV clinic, which is kind of surprising. It's something we'll talk about.
Wait, Chris, this means I forgot everything you learned.
No.
But why is that not? Why can't you say it?
Yeah, so we have an odds ratio greater than 1, so it's a trend, but I'm using a p-value cutoff of 0.05, and the p-value is 0.128, so not significant.
What would it be?
And this is the graphic, the plot of that.
Yeah.
So, discussion. Major findings. We support our hypothesis. Primary delay was associated with poor stage risk. This was cross-sectional, so we can't say a lot about causation, but we at least generate a hypothesis that there is an association there, and might be a factor that we could intervene on. And again, it shouldn't be assumed necessarily that delay is associated with poorer outcomes, as I mentioned, from a lot of the other cancers. And I think it's important to know this, particularly with an HIV-associated malignancy and with KS that does have rapid progression, that delay might be a more important factor than we might think. And then visitation to a traditional healer was associated with having status as a primary delayer, and was the only variable that was significant. And that's another thing we could think about maybe leveraging to get patients into the clinic faster. So just some other background information on delay. This is the most comparable cohort I could find to Uganda. This is the different kinds of delay for a range of cancers. And this is measured just as a continuous variable because they followed these patients. Due to patient recall, I couldn't measure primary and secondary delay as a continuous variable. I just asked them 1 month, greater than 3 months, 6 months, greater than a year. But tertiary delay we could measure as a continuous because I could look at their chart data and see what day they got their diagnosis and what day they started treatment, and found that this cohort is actually doing quite well. That pink bar I just put up was the the median tertiary delay for this cohort, you can see it does quite well compared to this. We are comparing a low income or low budget, I guess, government hospital in India to Uganda among different cancers, so take that with a grain of salt. And then the cancer stage. How are patients faring compared to other cohorts that have been staged? Our cohort is the purple, and this is the percentage of patients that have poor risk in each of the 3 categories. You can see quite a number larger in Uganda than 2 previous studies. One was in the US in '97, and the other was in Italy in 2003. But actually the patients, compared to other cohorts, are doing quite well with respect to immune system and systemic illness. And maybe we think a reason for that might be, if you remember, almost 50% of the cohort was on ARVs for at least a month. So that would certainly influence the immune system function, raising CD4 counts, and also systemic illness. And these cohorts, the cohort in the US was a low-income community in DC, which didn't have high exposure to ARVs. And the Italy study was a low-income group in Italy, but they did have higher access to ARVs. So just some takeaway. Although the higher percentage of tumor extent is an interesting finding, it might be concerning, especially, again, thinking about the burden of disease, how debilitating it can be. The association between primary delay and cancer stage is larger than previous findings among other cancers. So I said this delay the association between delay and poor stage or poor outcomes has been measured, but these have been really only done in high-income countries among breast cancer and acute myeloid leukemia, which is a very rapid progression or very rapid onset for that kind of cancer. They found the association. It wasn't as strong. Again, we're talking about different cancers, different cohorts, high income versus low income. So I'm not even sure that it's worth mentioning, but there you go. And then also, again, other studies have failed to find that association. Colorectal and bladder cancer are very different than HIV-KS, though. So this represents one of the first studies to examine empirically the link between delay and cancer stage among HIV-associated KS. And it suggests we might be able to, that intervening on primary delay might improve patient prognoses upon admission to the UCI. A large majority were in HIV care and many were exposed to ARVs. However, as I said, there was no association between HIV clinic attendance and having the status as a delayer. And that's something that's kind of alarming to us. We want to know why that is. Could it be that there's a lack of cancer knowledge of signs and symptoms by the patients? They're already in HIV care, but they develop spots. A lot of these things develop painlessly, so you wouldn't necessarily bring it up. A lot of patients told me they thought it was side effects of their ARVs. And then again, patients are often getting rushed through the line, so they're not necessarily bringing this up to the clinician. So the inability of HIV clinicians to diagnose or screen for KS. Physicians at the Cancer Institute told me that HIV clinics are very regimented. They have a list of questions. They ask the questions, give the pills, the patient goes. If they're not asking about cancer, tumors, lumps and bumps, spots, they wouldn't necessarily refer a patient with cancer. Or that they were aware of KS, they're waiting for a response on ARVs, which has been shown to happen, but they didn't inform the patient. I think this is kind of unlikely. I think there are certainly clinicians who are waiting for a response on ARVs, but I think it's unlikely that the patient was unaware of it. And the patient would have to be unaware of it to fit the definition of a delayer. So I'm not sure about that one. But what can be done? I think there exists a really great opportunity to leverage this HIV care to get patients into the Cancer Institute faster. And it certainly is not my idea, it's not a new idea. It's something that's being talked about quite a bit with non-communicable diseases and at the Cancer Institute specifically. But this is the HIV patient. Like most of our cohort, they're doing something in HIV care, whether it's counseling or getting that prophylactic treatment or on ARVs. At some point, they're developing signs and symptoms. So it might be before the clinic, it might be while they're at the clinic, but they're developing signs and symptoms. And they're either going to go to their local clinic and recognize this as distinct, or they're going to go back and tell their HIV provider about their signs and symptoms. At that point, the HIV clinic can do a lot of things. It can refer back to the local clinic, the district hospital, the referral hospital, and enter that patient back into the system. So they go back into the system and they complete the chain. Eventually they end up at the Cancer Institute. But what we'd really encourage is for a relationship between the Cancer Institute and HIV clinics. How can HIV doctors work to screen for cancer better, especially KS? And how can they, you can see that the pathway to care for the HIV patient would be much shorter. They could go from their HIV clinic straight to the Cancer Institute. Even if the HIV clinic refers to the referral hospital, which does happen, they still have to go through this ridiculous, I shouldn't say ridiculous. They have to go through an assessment center, which is a general inflow area for the entire hospital. This is a huge government hospital and can experience delays a week, 2 weeks, just waiting to get pathology back. So if there was a way that they could refer directly to the Cancer Institute, that could really intervene on this. Some limitations, selection bias. Most of my patients were from the outpatients department, just for ease of sampling. Although I did interview a number of patients on the ward, but that took coordination from the nurse in charge. So I might have missed some severely ill patients who are admitted on the ward. Most KS patients come every 3 weeks for their chemo and go through outpatients, and that's where I get them from. When you're interviewing people, especially asking them to recall their delay when they went for treatment, there's some bias there. They might not want to admit how long they waited, things like that. The study was cross-sectional. If we wanted to say more about causality, it would be nice to know when the patient delays, follow them, and do a survival analysis. And then also some of the staging things that we talked about, some of the inefficiencies. So in conclusion, decreasing primary delays may have a significant influence on reaching patients with limited disease, and that could be a factor that we could intervene on. And a lot of the solutions might be found in the health system, including traditional healers in the cancer care continuum. It'd be interesting to see an intervention to see if traditional healers would be open to the idea of being educated about cancer. There's a lot of antagonism between traditional healers and the health system in Uganda, and then also leveraging HIV clinics, which I already talked about. And then again, just advocacy for treatment for KS patients, especially advocacy for treatment with ARVs plus chemotherapy. From a policy perspective, it's kind of interesting to see what cancer is going through right now, because the sort of economic arguments that were made against HIV are being made right now against cancer, that you can't treat cancer in a place like Uganda. And we can talk more about costs and things like that. But some of the most preventable diseases, actually there are generics available, and annual costs aren't that high, relatively high. So yeah. Some acknowledgements, obviously the patients and staff. Dr. Jackson Orem is the director of the UCI, who allowed me to come, and my committee members, Dr. Zafar, Dr. John Bartlett, and Dr. Nixon and Seymour were on my committee. And then of course DGHI. Yay. Thank you.